Everyone fully rested, refreshed? Thank you very much. And sorry we've not been able to coordinate the watching our leader Sot on the TV. He has been on about 45 minutes ago though, so he has done his session. It will be available for you to have a look at if you want later today, I'm sure, on Channel 4. So let's kick off with the next session with an aspiration that we can finish between 3:30 and 4 o'clock and get you off. The next section is a state-of-the-art kind of section by Maria and Andrew, two separate presentations, just talking about what's going on in oncology, just a sense of letting people know in terms of education. So first up, we've got Maria. We'll take questions for Maria at the end of Maria's section rather than do a panel discussion. So if you've got any questions for Maria, try and collate them as Maria's making the presentation. Thanks very much, Maria.
Hello, everyone, and thank you for being here today. As a routine, I'm now used to giving talks on brachytherapy, and some of you may have heard me before. I hope I have a lot of questions in the end, and we can make this a bit interactive. I start by making a disclosure. I've been in a love affair with brachytherapy for over 10 years now, so I'm not going to try to make this very objective. I'll be biased towards brachytherapy. This is my guide for the plan. What we're going to talk about today is decision-making in prostate cancer, an introduction to prostate brachytherapy, and then talking a bit about the different uses of brachytherapy as low-dose rate, high-dose rate, and brachytherapy boost. So when we are seeing a new patient with a diagnosis of prostate cancer, and quite a few of us here are familiar with the joint clinics, there are many things that we need to take into consideration. So the patient's preferences, their profile of LUTs, their baseline sexual function, the prostate volume, age, comorbidities, life expectancy, and competing causes of death. This is very important. For a lot of our patients, prostate cancer is not necessarily the most important thing they have going on with their health. The anesthetic risk, the treatment toxicity, treatments available, social context. For some of our patients, they are the main carers for their wives, for instance, and they're not available to travel a lot. And also, what's the evidence-based medicine at this point in time? And my first statement here is that one size doesn't fit all. There are patients that will be suitable for brachytherapy. Some patients are better served by having a radical prostatectomy, for instance. And when we talk about surgery versus radiotherapy, this is very important to strike. They have similar oncological outcomes. The big difference between them is the profile of toxicities and future implications. So as you know, after a radical prostatectomy, radiotherapy is very standard of care and it's easy to deliver, while the other way around is not the same thing. So let's talk now about the best treatment for prostate cancer. This is just a very initial view on what prostate brachytherapy is. And I start by talking about the Radiation Hall of Fame. So it was at the end of the 19th century that we had a lot of important discoveries in our area, with the first picture of being the famous first X-ray, and then we discovered radioactivity, and later on in 1906, Pierre and Marie Curie discovered radium. And this is a very important date, 1906. And why this is important? Because 5 years later, in 1911, we actually have the first documented case of prostate brachytherapy. So it was adapted very soon after this, but probably have not heard it as a standard of care technique until the 80s, when we started doing it ultrasound-based, and it became much more easy to deliver. So why is brachytherapy such a great treatment? And this is a very simple answer, because the radiation source is inside the target, which is the prostate, while with external beam radiotherapy, the radiation is coming from the outside. Very simple. There are many advantages about brachytherapy. First of all, it's what we call the ultimate conformal treatment. It's very adapted to the prostate. It has a very steep dose fall-off, means that we can preserve the surrounding normal structures. It's one or a limited number of treatments with very good and long-term documented oncological outcomes, a good profile of toxicity with an extended follow-up, and it's also a good technique when we need to treat a prostate for a second time. So we have basically two techniques of brachytherapy: the low-dose rate, the seed brachytherapy, Quite often the patients will refer to it as the pellets, the seeds, or the high dose rate. So in the high dose rate, what we use are needles, as you can see on the picture on the right, and those needles are hollow and a radioactive source goes inside them and delivers radiation with extreme precision to the prostate. So we can use brachytherapy in different scenarios. So if the patient is treatment naive, we can use low dose rate and high dose rate as a single treatment, or we can use it in combination with external beam. That's what we call a boost. And also, which is a completely different scenario, you can use it for local relapses. And in this situation, we call salvage brachytherapy, also with both techniques, seeds or high dose rate. This is the standard setup for prostate brachytherapy. So the patient is in lithotomy position. We use a transrectal ultrasound, and through the perineum, usually insert 14 to 20 needles, depends on the prostate shape, side, and the technique. And we use this template on the right side that the surgeons very happily stole from us when they adapted the transperineal technique. Yes, we had it first. So it's pretty much, as I usually say, a battleship technique. We use the coordinates to insert the needles in the prostate. Let's move on to discuss low dose rate, brachytherapy. So if, as a rule of thumb, this is the kind of patients we want you to be thinking about for low dose rate brachytherapy. T1 to T2 disease and a combination of Gleason 3+3 with a PSA of less than 20 or a Gleason 3+4 with a PSA of less than 10. And we also want a patient with a really good urinary symptoms profile. So an IPSS ideally below 8, but it's acceptable until 19. And I'm also, the people that work with me know that I'm a bit obsessed with the flow rates, and I will ask for flow rates for all my patients having brachytherapy. And we want a Qmax ideally above 15, but acceptable above 10. And then the question is, can the patient be on a alpha blocker, yes or no? You'll have different answers depending on the center. For us at the Christie, we will do HDR on patients on an alpha blocker. We tend to not recommend on the LDR patients because of the concerns with the side effects. And we also want to have a nice graph of a flow. Jeremy, I did learn something from you the other day. He's ignoring me. So we want this kind of flow rate is the patients we want for brachytherapy. We want a quick and high peak flow and that the patient drops very quickly. And there's the important thing when you're looking at the patient's MR report and it mentions a thick-walled bladder. It may put us thinking, is this the right patient for brachytherapy? Do we need to do something else to investigate this? And for brachytherapy, size does matter. It's an important parameter to look at before offering the patient brachytherapy. If we have a patient with a really small prostate, in very simple terms, we don't have enough tissue where to introduce the needles. And we end up in two situations. Either we have a high dose of radiation to the urethra, and hence we increase the side effects, or we have, if we want to keep the urethra within our limits, we have a poor coverage, and then we compromise the oncological outcome. This is not what we want. If a patient has quite a big prostate, then we have a higher chance of the patient going into retention, and you also have a higher chance of what we call pubic arch interference. Some people in the room that may have been doing transperineal biopsies may be familiar with this. So if we look at an ultrasound image, basically if the prostate is very large, then the bone here is very close to the prostate and we are not able to introduce the needles. So we end up in a situation where we have to compromise on the coverage of the prostate. If we look at the textbooks, there are several contraindications to brachytherapy. Some of them are absolute, some are relative. And of course, it's important to look at the anesthetic risk of these patients. They put here on the absolute, the anticoagulation. This is not the case. Depends on the situation, and we can look into this. And also the relative contraindications, a large TURP defect. It depends. How long was this done? How is the patient anatomy looking? But as a rule of thumb, we don't really like doing brachytherapy on patients with a previous TURP. And for seed brachytherapy, there are 3 different isotopes that can be used, iodine, palladium, and cesium. In Europe, all of us use iodine, so the other ones are used in places like Japan or America. Just to be aware that there are different ones, but in Europe, everyone uses iodine 125, which has a half-life of 60 days. There are different brachytherapy techniques, and the one we use here at the Christie is what we call a two-step procedure. So it's 2-day cases. The patient comes to the Christie twice. In the first one, we do a volume study, which is basically taking ultrasound pictures of the prostate, and then the patient wakes up, goes home, and offline we do the planning. We order the seeds that come from America, custom made for that patient, and on a second step, about 2-3 weeks later, we implant the seeds. Again, a day case, the patient doesn't stay in the hospital. However, there are the centers that use what's called a one-step live plan technique, and basically all of this is done at once. The patient comes into the hospital on one day, we acquire the images, we outline the prostate, we plan, and we introduce the seeds. There are different types of seeds and different ways to do seed brachytherapy. Basically, you can have loose seeds or stranded seeds. If you're curious about the seed, they're about 4 millimeters in length, so they can be seen. This device here called the MIC applicator is used to introduce loose seeds. The ones we use at the Christie are stranded ones, and this one is a set strand of seeds and spaces, but this can be done in a different way. Or there are also techniques where you can build your own strand, like this one here during the procedure. And again, all of this can be used in combination. We can use just the loose seeds, we can use stranded seeds only, which can be pre-made or built during the procedure, or a combination of loose and stranded seeds. The team down in Guildford developed a technique called 4D brachytherapy, which a lot of the centers in the UK are using. And so what they do in this one is that the peripheral needles here are all preloaded and stranded. So this is a preset array of needles, if we want to call it like that, and then during the procedure we just plan the central ones, and these ones can be done in a different way. And it's a British development, was a technique made by the team in Guildford. Then there is a legal requirement that we do post-implant dosimetry, which is basically we do a CT 4 to 6 weeks after the implant to see where the seeds ended up, and that the dosimetry of this implant basically gives us a chance related to the oncological outcome. However, the important question about post-implant dosimetry is that what if it's not very good? We don't tend to go back and do anything. In theory, you could go back and introduce a few more seeds in those patients. So what about toxicity? This is quite all very well established. So in regards to LUTs, the most immediate risk after seed brachytherapy is retention, as the one that we are mostly concerned. The patients have a peak of urinary symptoms at 6 weeks, and then it goes down over time. The main symptoms to be aware of, if you do see a patient, are the storage symptoms, which can sometimes take 9 months to resolve. This is something to be important to tell the patients about. It may take a long time for the urinary symptoms to go back to baseline. We don't really count on bowel problems, and in regards to the sexual function is by far the best technique. This is a comparison between a bilateral nerve-sparing radical prostatectomy and C technique done by the team at MD Anderson, and the LDR brachytherapy is basically the blue line on the top, so less impact on sexual function. In regards to the English experience, again, the team at Guildford looked at their experience of patients who were under 60, and if they were potent before brachytherapy at 5 years, 75% of them remained potent. So this is by far the best, the treatment with less impact on sexual function. In regards to oncological outcomes, this is a long-term follow-up by the Princess Margaret Hospital in Toronto, and overall the patients do extremely well, very good cancer control after 10 years. And this is another important part to be aware of, which is the PSA kinetics. 20% of the patients who have seed brachytherapy will have a PSA bounce in the first 2 years. This is important to tell the patient so they don't get anxious about it. It's normal that the PSA is going down and then suddenly it goes up. People have tried to come up with the reason why this happens. No one is able to know. We don't know if it's a good thing. We don't know if it's a bad thing. It's just so that the patients are aware of that this can happen, okay? And the other thing to tell, and I think that's really important to manage patients' expectations, the PSA nadir, so the lowest PSA the patient can reach is often 3 to 4 years down the line. So tell the patients up front about this. They shouldn't expect that the first PSA measurement they have is the best one. The PSA drop is slow and will take time. And the group in Canada and US published a paper a few years ago. We don't have a definition of failure after brachytherapy. We just use the same one that we use for radiotherapy, which is nadir +2. So that's why we defined failure after brachytherapy. But now they looked up at their long cohorts and basically came with a definition that if a patient has a PSA of less than 0.2 at 4 years, they are cured, because there's a very limited chance that the cancer can come back in the future. There's one interesting thing about seed brachytherapy, which is you cannot forget the patient is carrying a source of radiation. So once a patient gets seed brachytherapy, they'll have a card that identifies them as carrying a source of radiation. You need to let the patients know a few things. First of all, they may trigger airport security. So it's something that may happen. It has happened before. They also need to be informed that they need to use a condom the first few times they have sexual intercourse because of the risk of a seed coming out during ejaculation. And the other thing, again, it's a legal requirement, is that they pass away due to any other cause in the first 2 years after the seed implant. They cannot be cremated, they need to be buried, or the prostate needs to be removed. So there are a few concerns with radiation protection in patients after LDR brachytherapy. So what about high-dose rate brachytherapy? It's done in a completely different way. So the patient is in the same position. We still use the ultrasound, we still use the template, but then we have transverse tubes connected to an afterloader, which is where the radiation source is stored. So what happens once the treatment is taking place is that the patient is there on their own in theater, and we are monitoring him remotely from a different control room with cameras looking at the patient and at the monitors. Again, different templates. We use the needles, the metal needles. We use a stepper and we use the afterloader. This is like the new one that we have too. An important thing about the HDR technique is that the first 1 centimeter at the top of the needle is a dead space. So basically, if we want to cover the top of the prostate, we need to push the needles inside the bladder. That's just the standard technique. That's what we do for all of our patients. And as the LDR, HDR has also evidence for monotherapy, and it's a great technique. The profile of side effects is probably better than the LDR. It's not as prolonged in time. And if you think that with the LDR, we need to spend a certain amount of money per patient in the seeds, with this one, we just have the source that, for instance, we already use a lot for the gynecological patients. So it's a reduced cost. And again, there's no radiation protection concerns because the patient is only the effect of radiation while the treatment is taking place, but they don't carry the radiation with them. There are many ways to deliver HDR brachytherapy. Our workflow is based on ultrasound, so we do everything in theater, ultrasound guided. We are very lucky. We have our own theater, our own brachytherapy ward, but there are smaller departments in the rest of the country that don't have that, so they only have access to theater for a short period of time. They do the needle insertion with ultrasound guidance, and then they wake up the patient, take to the CT, do planning, outlining and planning, and delivering the treatment in a different area. HDR monotherapy has evidence to be used as 2 different implants or a higher number. Over time, we were getting very excited in the brachytherapy community because we thought, so if we can do LDR in 1 treatment, why can you not do HDR in a single treatment? And over time, several people in Europe did clinical trials looking at just delivering 1 fraction of 19 gray. Although this was very exciting, it actually completely failed. And this was demonstrated ultimately by a randomized trial done in Toronto in Canada, where they compared with HDR monotherapy 1 fraction versus 2 fraction, and the hazard ratio for local failure was almost 22, which means that the local relapses on one single treatment was much higher than in two treatments. And because of this, we came to the conclusion that there was an unacceptable level of local failure in this treatment. Basically, all worldwide, we lost a bit of interest on this. This was also demonstrated in Spain, in the Netherlands, even here in the UK. What we do much more often than the HDR monotherapy is boost, brachytherapy as a boost. And this, again, the UK led the way in a trial done by Peter Oskin, and it was published back in 2012, so over 10 years ago. And in this trial, which was a phase 3 trial, HDR brachytherapy was compared to external beam on its own. However, if you do notice, and if you do remember the doses that we use nowadays, the dose of the standard of care arm was a bit lower than we would consider. And in this trial, they included patients on intermediate and high-risk prostate cancer, with the primary endpoint being biochemical control. And what this showed was amazing. And basically, with HDR brachytherapy boost, the biochemical control of prostate in intermediate and high-risk prostate cancer is much higher. And the cherry on top of the cake is that although we increase the cancer control, this doesn't come at an increase in side effects. So similar side effects, but higher oncological control. And a few years ago, the Canadians again published another trial, this time with SEED as a boost. It was called ASCEND-RT. Again, intermediate and high-risk prostate cancer, and the patients started by having the external beam radiotherapy part of the treatment, and then they were assigned to have an external beam boost or an LDR boost. Again, what this demonstrated is that by giving the brachy boost, the biochemical control was higher. And this was true for both intermediate and high-risk prostate cancer. But what this also demonstrated is that with SEED brachytherapy, the amount of urinary toxicity was much higher than compared with external beam on its own. We don't have a good reason for this. It may have to do with the technique on how they perform the SEED implants. But although it was very good for biochemical control, there are concerns with using this technique because of the urinary symptoms. There was no relevant difference in regards to bowel symptoms with the use of LDR brachytherapy. And again, I'm going to use this opportunity to talk about something different that we are doing at the Christie right now. We are very proud to have this trial open called ROPIP. We have a trial open for patients who have a local relapse of prostate cancer after primary treatment with brachytherapy or external beam radiotherapy. This is a feasibility trial in which we are comparing HDR brachytherapy with SABRE, our more fancy radiotherapy technique, the treatment with just 5 fractions. And this is a trial that is open with us at the Christie, also in Leeds and Mount Vernon. We are hoping to recruit 60 patients for this new technique. Very proud to say that we treated the first patient nationally just over Christmas. And if you're interested, and if you have a patient who has a local relapse, who is young, who has a good urinary function, and if you want to consider them for the trial, we are very happy to have the discussion about it. So prostate brachytherapy is an excellent treatment, but you need to select well the patients. The blood profile and the prostate volume are key when offering this to the patient. LDR is one-off treatment for low and low intermediate risk prostate cancer. HDR monotherapy has similar indications to LDR, but requires at least 2 treatments instead of 1. And you should think of brachy boost for intermediate and high risk patients, and HDR is the preferred technique. And I have a few cases for us to do a bit of a practical exercise. And the question here, so this is a 73-year-old gentleman with a benign DRE and the PSA 4+3, Gleason 3+4. And the interesting thing about him is his prostate volume is only 12 cc. So the question for you is this a right patient for brachytherapy? Yes or no? Who votes for yes? Hands up. Everyone is shy. Or no? No? No, it's not the right patient for brachytherapy. The prostate is too small. Even the surgeons would like to operate on these cases, right? Very small prostates make it a bit more challenging. So no, small prostate, not for brachytherapy. Another case, this is a 69-year-old gentleman, T2C N0M0, Gleason 4+4, PSA 12.3, IPSS 15. Is brachytherapy right for me? Yes? No? Who votes for no? And the answer is no. Yes, this patient has a massive median lobe here on the MRI images. It's very difficult to get good dosimetry in a patient like this. So no, brachytherapy is not right for me. And last but not least, a 69-year-old T2A at 0, Gleason 4+3 with a PSA of 7.2 and IPSS of 17. Is brachytherapy right for me? And I didn't talk about this one, so I'll give you the heads up. All these calcifications in the prostate provide really poor images during the procedure. So it's not an ideal brachytherapy patient. And that's the end. Thank you so much.
Thanks, Maria. Can I join you at the front here? Thank you very much. So, is Jeremy still here? He's a man who should be able to ask some taxing questions as our resident expert. So while Jeremy's about to grab the microphone and others are thinking, so Maria, one of the big things that's hit us in urology is this PROTECT study in March. So in one of the most famous journals, the New England Journal of Medicine, there was a landmark paper looking at long-term survival and some other measures, depending on what treatment you have for localized prostate cancer. And it showed some results that suggested that treatment in lower and intermediate risk need to be careful. There isn't such a bad outcome if you do nothing. So can you tell us about that in terms of overall your perspectives, and particularly with respect to brachytherapy?
I think that's a very interesting question, isn't it? And I think that we all in this room probably very familiar with Predict Prostate, which is something that we all embraced as routine in our joint clinics. And it's quite extraordinary to notice how little impact the treatment has in a lot of the patients that we are seeing. And quite often in a patient in his late 70s with a Gleason 3+4, you're looking at overall survival of 1% over 10 years, which is minimal, isn't it? And I think we need to bear in mind those numbers when counseling the patients, because we do appreciate that a lot of times they are very anxious, and we understand that they are anxious, but the risks of side effects are in fact higher than the benefit in regards to cancer control, and we need to have this open discussion with the patients.
So Jeremy, sorry I put you on the spot, but you are a super specialist in this area.
Possibly not. I'm going to make just one comment and then a question, if that's okay. So I think the first comment, I think Maria hinted at there at the start, is that one size doesn't fit all, and that's absolutely the case for prostate cancer patients. What Maria does, Maria has a joint clinic with Maurice Lau. I have a joint clinic with Reed Conroy, and we work absolutely together from the MDT stage to the clinic stage, to the treatment. We sit there and we talk about the pros and cons of each treatment. And in particular, you can do that with the patient at the same time. So I'm an absolute convert to the idea of joint clinics and joint assessment as being critical for, it goes all the way back to the start. We were talking about how do we individualize care. This is critical because there are plenty of patients we saw there, which brachytherapy is not right. But equally, there's patients I'm going to see, and I can tell Maria surgery is not right. And so that's why by sitting together and actually having those joint conversations, it makes the world of difference. And I'm a big advocate, and I absolutely will say to my patients at the start, radiotherapy, brachytherapy is just as good an option, but it's going to be, for some people, it's going to be better. The question, the Curies, what did they die from? So remember the advocate, Marie Curie and her husband, what did they die from? They put their ovums from their brachytherapy in their back pocket. So they used to walk between patients and they had the radiotherapy seeds in their back pocket, and they got sarcomas and cancers and things like that.
They did. They didn't know about radiation protection, which we do know nowadays. But that's also quite an interesting point, isn't it? And I didn't talk about that today, but we have debated this before, Jeremy, haven't we? And when we are in clinic and the patient that we have in front of us is 52-year-old, but he actually needs treatment, I will put my hands up most of the times and say, I'm sorry, but radiotherapy-based treatment is not for you. And the reason why I'll say that is because I expect that patient to live a long time. And in this group of patients in particular, we need to counsel them against the risk of second malignancies caused by the radiation treatment. There is some data that suggests that with seed brachytherapy, there isn't an increased risk of second malignancy compared to the surgery. But if it's external beam, there was always a margin to what we treat. There was a radiation dose to the bladder, to the rectum. And if you can avoid the risk of second malignancies 20 years down the line, we need to bear this in mind when discussing with a patient, which is completely different when we have a patient who is 75 in front of us.
Yeah. Any more questions? I've just got one just in terms of scale. So you've got a man, an average man. I know it's difficult because you've got patients who are suitable and not suitable. But broadly speaking, how many men have surgery? How many men have brachytherapy, external beam, and how many?
I think there's quite a bit of equipoise, isn't it? We have a very open, transparent discussion with the patients. And there are a lot of patients that will decide to want radiotherapy, and also quite a lot of them will decide to have a radical prostatectomy. So I cannot put a number to that because I don't think that there is a clear winner.
Half and half, because a lot of patients are higher risk, or too old for surgery. So we will have a lot of patients who don't offer operations too. So I'd say my feeling would be it's probably 60 to 70% of patients will go down the line of radical radiotherapy. But there is data to say that the higher risk patients do better. So I would all be counselling my higher risk patients. They will probably do better for radiotherapy, even if they are suited for surgery as well. So the data goes kind of supporting a little bit more radiotherapy for those ones, but ultimately, it's probably I'd say 60-70%.
Maybe.
Yeah. Okay, can everyone join me in thank? Oh, sorry, we have another question. Sorry, just saw it there popping up. Thank you very much. Last question.
Thank you. So you say about not all of them is actually suitable for brachytherapy.
Yes.
Do we have like a guide of who actually might be? Because we don't want to send a patient that is not suitable or is not appropriate. Do we have like a guide where we can?
Because you need to take many things into consideration. So there isn't like a simple flow chart for who's the right patient for what. It is really an assessment of everything: the prostate cancer features, the prostate volume, the LUDS profile, the comorbidities, what's the anesthetic risk of this patient. You need to take all that in consideration before counseling the patient on brachytherapy.
It's the same oncologist providing the brachytherapy and the external beam. So you send them for radiotherapy assessment, they will do that for you. Same as surgery, you could say on paper, this man may be suitable for surgery, but I may get him and then go, crikey, couldn't touch that. So that's again, it's the benefit, it's the benefit, to sound like a broken record, of a joint clinic, is we can do those assessments and do them well.
I guess it's the importance is also filling in the MDT information correctly, so the MDT can start that process, and that you have a proper shared decision making where the nurses and other colleagues come into that conversation, as well as the surgeon and oncologists. And that's what we've got in Manchester. We've had a brilliant shared decision making service in prostate cancer that we've had for 20 years. Richard Cowan, Noel Clark started that ages ago, and it's worked really well, I think. Okay, thanks very much. So next up, the next expert, we've got Andrew, who says he's going to just slightly change the topic, but essentially he's going to talk about bone health and new novel treatments in prostate cancer, an area many of us find quite confusing, Andrew. So.
Thank you very much. That's great. Yes, thanks for that. So I am going to change it a little bit, but before anyone leaves, it's going to be very similar to what what I was asked to talk about, but basically things have changed quite a bit since I was asked to do this talk. So in the last few months, there's been a real shift in kind of genomic medicine for prostate cancer. We're entering the new genomic era for I suppose, the treatment of prostate cancer. So I'm going to go through the first bit as promised, novel agents and bone health, and then I'm going to speak a little bit about kind of, I suppose, the pathways that we may be trying to think to set up with GM cancer to get our patients tested for cancer genomics, to quantify their risk, and I suppose to allow them to have some of these novel treatments. So basically, I work with Maria at the Christie. I lead the research clinic. So we have 2 clinics a week where we're testing medicines. Some medicines have never been tested in humans before. We recently had a patient in a study who was the first person in Europe to receive a prostate cancer medicine. So I see a lot of metastatic patients. This talk is about metastatic patients rather than, I suppose, radical patients, as Maria has discussed. So I suppose, first of all, we look at the pathway for the patient that's been treated for metastatic disease. And really, there are 2 halves to this pathway. There's the first half when patients are diagnosed and they might be hormone sensitive. So a lot of the treatments there are hormonally based. And then as time goes on, the patient becomes hormone resistant, sometimes called castrate resistant. And then the patient will probably receive things like chemotherapy. So I suppose there's less of a focus on hormonal therapy, even though we do give novel hormonal therapy in that setting. But you can kind of break it up into two halves. And the first thing you would notice if you were an endocrinologist or a rheumatologist would be that most of these treatments are very toxic to your bones. So we know that in female patients, when they go through the menopause, their bone density goes down. Well, we're doing this to our prostate cancer patients. We're pushing them into a state where they don't have the testosterone that they would normally lay down new bone. So our treatments are quite damaging to bone, and we need to think about how we can counteract that, especially since patients will be on these treatments for many years. Now, the bad news is it all goes downhill from about 35 years of age. You start to lose bone density then. And you lose about 1% of your bone density a year after that age in men. And when you get to 50, the life that you have ahead of you, there's a 1 in 5 chance of you getting an osteoporotic fracture. And I'm not talking about prostate cancer, I'm talking about everybody. So the risk is high of an osteoporotic fracture in our patients. We know that testosterone suppression for prostate cancer increases that risk. So this is just a study looking at everybody, even radically treated patients. And if they had hormonal therapy as part of their treatment and they survived 5 years, they were much more likely to have a fracture. We don't know if they were all fractures because of osteoporosis, but we know that about 1 in 5 had a fracture 5 years or longer after their treatment. So we know that testosterone suppression is damaging to bone, and there have been lots of studies that have shown that. There's also been studies that have shown that you start to lose your bone density as you're on the hormonal therapy, androgen suppression, and then the most significant loss occurs in the first 12 months. So that's critical to try and prevent patients, getting these problems. And then finally, in the kind of novel hormonal therapy age, we now know that those patients are even higher risk of having fractures. And Craig Jones, who's in the audience, he's done some work looking at the novel hormone risk, and he presented it to the oncologists here, and I'll tell you what we did about that information. But we also have data from other clinical trials showing that novel hormonal therapy is particularly toxic on your bones, and you are at risk of having these hip fractures or vertebral fractures. So what's the current action? Well, unfortunately, there's no nice recommendations about bone health. And in some ways, the nice recommendations impair us because they talk about bisphosphonates for prostate cancer and are very negative based on the fact that they can't really be used as an anti-prostate cancer treatment. I think people have extrapolated that and thought, well, we can't possibly give any bisphosphonates to our patients. So there are no nice recommendations. GM-wide, what we've done as a group of our, I suppose, 9 consultant oncologists working in prostate cancer is we've decided that there is enough evidence to give all patients bone protection if they're going on novel hormones. So that's what we've started to do, and we decided that this year following a presentation from Craig. I suppose when we're thinking about more patients, I mean, novel hormone patients are particularly at risk. We are trying to still work out what we're going to do with our other patients just on androgen deprivation therapy. And we're doing a pilot study as part of the GM Cancer Pathway group, that we had a subgroup looking at bone health. And we now have a pilot study where we're trying to use FRAX scores and DEXA scans to work out which patients will need bone protection. So there is movement on this. We're treating our patients on novel hormones with bone protection. We're nearly there with some of our other patients. There are clinical considerations. So I see these patients in my clinic. I start them on a novel hormone. I ask the GP to add these things to their repeat prescription. There are things that we need to bear in mind when we see the patient at that visit. First, that this risk of osteonecrosis of the jaw, most of us have never seen that happen. It's a rare side effect. And if you ask any medical student about bisphosphonates, that's the first nugget of information they will come out with. But actually, it's very rarely seen. But because when it does happen, it can be a terrible experience for the patient, we make sure that anyone that's going to go on these bisphosphonates have a dental assessment. And that's getting increasingly more difficult in the NHS. But what we like to do is try and get these patients reviewed by a dentist before starting. And certainly if they've got active issues, if they've got teeth that are falling out or anything, it is really important that they get seen first. Kidney function is also important, so we're going to ask the GPs to prescribe this medicine for us, and we need to give the GP some guidance about what the renal function is like, because when you go below a certain renal function, 30 mils per minute, bisphosphonates are contraindicated. So we need to know that as well at the visit. And then we also need to educate the patient about how to take these, so you have to sit up. It can cause some irritation, can the bisphosphonates of the esophagus. So we try and go through that with the patient in clinic. So that's bone health. There's a lot more that could be said on bone health, and I was going to say a lot more, but then some other things came along. I think it's more important that we talk about those, but if you want to talk about bone health at the end, we can do. So we've now entered this genomic age of cancer, and as a reward for that, I'm going to treat you to some cellular biology, which I know you signed up for this not expecting to go through cellular biology, but I'm going to explain just a little bit so that we can have a discussion about certain things, because my aim is when you leave here today, you understand about the genomic testing that we want to do, what's the difference between germline and somatic, and when might we be testing these patients, because we will be testing them in the future. And I think to understand that, we need to understand just a little bit of cell biology. So, you've got two pictures there, normal cells and tumour cells. And the normal cell bit is probably you remember that maybe from A-level biology, I don't know. You have these chromosomes, you got 23, you get one from your mum and one from your dad. They're exactly the same. They're a copy of each other. They're not exact copy, but they have the same genes, or they should do. And basically, they determine everything that your body does, everything that your cells do. Tumour cells, if you do the same thing and look at the same thing for tumour cells, they're all mashed up. And you can see that there's some there that have 2, some have 4 or 5, and then there's all these other bits on the bottom that are all fragmented and they're all joined together, it's all random, it's all chaos. And that's the difference between normal cells and tumour cells, normal cells and prostate cancer cells. And why does this occur? Well, one of the reasons it occurs is because of the way that the cell repairs its DNA. So there's a thing called BRCA2, which is what we're going to be talking about testing. But what BRCA2 does normally is it repairs all those breaks, because these things are happening all the time in all these cells all the time. And you get breaks in your DNA because it's like spaghetti going around your cells, and it pulls and it breaks. And you need BRCA2 in your cells to join them back together. Because if you don't, you end up with a big mashup like that, and all your cells, they get out of control. So BRCA2, if you've lost BRCA2 in your cells, it's really damaging and it can cause cancer. And that's why we see patients with BRCA2 mutations. That's why they get cancer at an early age. So, there are things in the news out there about breast cancer and prostate cancer, and patients having operations to try and prevent that from happening. Now, because you've got those 2 copies, you've got one from your mum, one from your dad, you've got a backup already. So you get 2 copies of every gene. So you've got 2 copies of BRCA. And that's your germline. So when we talk about germline testing, that's what we're testing. We're testing about the genes that you got from your parents. To become BRCA deficient, you have to lose both. So you've got that backup. So if you lose one in your cells, you're okay, you can carry on. You've got enough BRCA to repair your cells and carry on. So you need to lose both. Now, how do you do that? Well, most of the time, you end up inheriting a bad copy from one of your parents, so you're already one down. And then you get another one that just occurs randomly because of cosmic radiation or carcinogens or just bad luck. And that's the difference between a germline mutation and a somatic mutation. So a germline, you got through your germline, which is basically what you inherit, and that's what you pass on. Whereas somatic is a new mutation that occurs in a cancer. So to lose BRCA, you've got to lose both. So what happens is patients inherit one and then they develop a cancer at an early age because they lost one and they lost their kind of fail-safe system to prevent that from happening. So when we talk about BRCA testing, we're talking about either germline, which you can test from any cell in the body because they all inherited that variant, or you can test somatic, which is the tumour. So you only have somatic mutations in the tumour. Everything else, that's normal, no mutation. So you couldn't look for a somatic mutation in a blood test. You'd need a bit of the tumour. And as I said, the only thing to remember is that germline can be passed on. So you've inherited it and you can pass it on. Somatic, you can't. So when I was first asked to do this talk, we couldn't do any germline testing. That wasn't available to patients in the NHS. But since I've been asked to do this talk, in the last couple of months, this has now been added to the NHS test directory so we can start to test patients. And we need to work out how we're going to do this for all of our patients that we see. And you're eligible for testing if you're young. So if you're young and just have any prostate cancer, if you're in your 40s with any prostate cancer, you can be tested. If you're in your 50s or younger and have metastatic disease, you can be tested. If you have Ashkenazi Jewish heritage and a prostate cancer diagnosis, you can be tested. And then if you've got high risk, so if you've got lots of family members who may have had prostate cancer at a young age, you can be tested. And we can do that from today, and we're starting to test patients to find out what their familial risk is, to see what the risk is to their family, what the risk is to their offspring, obviously, what their risk is of having these cancers that can be associated with BRCA2, such as prostate and breast cancer. So when we're testing these patients, we have to be thinking about that, about their predisposition, but we also have to think about other things. So it's not guaranteed. So if you've got a germline BRCA mutant or variant, it's not guaranteed that you're going to pass it on to every child. You pass on either your normal copy or your abnormal copy. So if you pass your normal copy on, the offspring wouldn't have anything. But approximately 50% of your children will have the variant because that's the odds of passing it on. If we are testing, we also need to think about the implication on the family members and the patient. They might have to go through testing. If you test a patient, prostate cancer patient, they've got a BRCA variant, you may then have to test their family to find out their risk, which can cause anxiety about the test and also the cancer risk. And I suppose there may be things in the future that we have no control over. So what if health insurance companies want to know whether or not you've got a BRCA or you've got a family that's got a BRCA variant? That might impact on your premium, or even them even offering you insurance. So those are things that we have to tell the patient about. And therefore, we need staff trained in all of this before we test them. So the NHS test directory has said that we can start to do it. So oncologists and urologists and their departments can start to test patients. You don't have to, before you had to go see a geneticist, but you don't anymore. So we have to think about how we're going to do this and how we're going to tell our patients about all these things before we test them. Now, my experience of doing it is that most people want to be tested, but we have to check, and we have to do it in a way that reduces the anxiety for the patient. So that's germline testing. So a new thing, we can now test all of our patients for the germline. Now I want to talk to you about testing again, but for patients having treatment. And this is somatic testing. So this is the acquired mutations. So before we do that, we just go back to this pathway. So you can see this pathway kind of is made up of two main types of treatment. So prostate cancer for a long time now has just been based on two main types of treatment. We've got hormonal treatment, where we're trying to manipulate kind of the either the environment around the tumour or inside the tumour hormonally. Or we have, when that stops working, we have cytotoxic treatment, which basically means chemotherapy. So this is very damaging medicine that is useful and is right for lots of patients, but it does cause a lot of side effects. We're basically poisoning the cancer. We're giving a cellular poison that poisons the normal tissue as well. And that's all we had. That's all we had for prostate cancer. We could either mess around with the hormones, really, or you could give a cellular poison. But there are new things. So we're entering this new age of prostate cancer treatment. And the first thing that's kind of broken through are PARP inhibitors. And we can start giving these today in our clinic. So a bit more cellular biology. So DNA is double-stranded. In your cells all the time, in every cell of your body, thousands of times a day, that spaghetti that makes up the DNA is breaking apart. And most of the time, it's just one of the strands that breaks, so the other one stays in contact and kind of holds it together. But if you don't repair it in time, you get another one and you get a double-stranded break. And if you get double-stranded breaks, that's when the cell dies. Now, I know I already told you that if you get double-stranded breaks, you get a cancer. So how can I now be telling you that these things are important for cancer survival? Well, the difference is the frequency they occur. So if I'm telling you that DNA breaks 1,000 times a day, if you don't repair all of those bits of DNA, it's going to be soup inside the cell. That's not going to be survivable. So we need to think about single cells having single strand breaks and needing to repair them in time, and this happening all the time in your cells. Now, PARP is really important for that, because what PARP does, so I told you that BRCA repairs double-stranded DNA. PARP repairs a single break in a DNA. And they work together, again, as a backup. So we've talked about backups for different genes. This is now backup for DNA repair. The body is really good at having backups. And we can exploit this against cancer. So PARP repairs single strand, BRCA double strand. If we give a medicine called a PARP inhibitor, so olaparib, and these things that are going to come into our clinic, we get rid of the cell's ability to repair a single DNA break. So all those thousands of breaks that occur, they all turn into double strands. And BRCA2 is really important for the cell to survive. If you've got a BRCA2 deficient cell, so we've talked about these, having a predisposition in your familial line and another mutation, meaning that you've lost BRCA2. So if you've got a prostate cancer that has that BRCA2, you don't have that backup. So we get rid of the PARP inhibitor. So we get rid of the PARP with the PARP inhibitor, and you've lost the BRCA already. That's a double hit, and you will start to kill the cancer cells. So that's excellent. So now we have a treatment. So unlike chemotherapy, that affects all the cells in the body, we have a treatment here that basically, if you've got normal cells and you've not lost BRCA, no impact or very little impact. If you've got a cancer cell that's lost BRCA, devastating. And this has been found to be the case, not just in the lab, in dishes, but in clinical trials. And this is a clinical trial using a PARP inhibitor, an oral medication, not a chemotherapy, an oral medication that you can give in the clinic, and it controls BRCA2 mutated prostate cancer. So off the back of that, it's now been approved. And again, if you were to ask me when I was asked to do this talk, could I talk about this? No, because it wasn't available. But all of a sudden it is. But you have to have a BRCA mutation. We talked about germline testing for familial risk. And now, if you want to have this treatment, we have to see whether or not you have a somatic mutation. So we've gone from, at Christmas, not needing to test anyone for genomics. Now we're testing lots of people. So I'm going to talk about the implications for that. I just want to highlight some other things that we're doing with PARP inhibitors. So I suppose that you know that we're continuing with this PARP inhibitor stream. So I say in the research clinic, we're developing new PARP inhibitors with AstraZeneca. This is a PARP inhibitor that's specific for DNA damage rather than what we also see sometimes is patients get anemia on PARP inhibitors. So we're trying to develop a PARP1 inhibitor with AstraZeneca. So we're doing that study in the clinic. And also a joint study with the surgeons. So we're hoping to get this off the ground to start maybe at the end of this year or next year, is we want to see what happens with this PARP inhibitor in specimens. So patients, when they're going to have surgery, we're going to give them this new PARP inhibitor. That's only been used in about 30 people worldwide. We're going to start using it and then finding out when they had their resection what it actually did to the cancer. So I highlight this really as a good joint project between surgery and oncology, because both partners are critical for the success of this study. So we talked about PARP inhibitors, and I've said that the genomic age of prostate cancer is coming. It is, so I'm going to tell you just about a few more that haven't made the mainstream yet, but maybe if I was talking to you in 2 years' time, I would also be adding this to a list of things that we're going to test in our patients. So at the Christie, we do the Capitello study, and this is based on another genetic target. What you can think of this is as so AKT in a cell is the accelerator and P10 is the brake, and that basically determines whether or not a cell divides. In some cancer cells, they've lost P10, and you can detect that genetically on a test. And when they lose P10, the accelerator, the AKT, goes into overdrive, and the cancer divides very quickly and is resistant to treatment. So we're testing this new medicine called capivasertib, Capitello study. And to go in that study, you have to have a genomic P10 loss. And other studies have shown that similar medicines work if you have a P10 loss. So we'd have to test genetically for a P10 loss. Finally, there's another study we're doing called the ODM study. And this is, again, an early phase study that we're hoping to do in a phase 3. So what happens normally is you get rid of that hormone, that blue diamond there, represents testosterone. We got rid of that. That would normally bind to that androgen receptor and activate it. That's not happening when you've had androgen deprivation therapy. There are other hormones in the system that are floating around trying to activate the androgen receptor, but they can't. They're not the right shape. That's what's demonstrated on the right. What can happen, however, you can get a mutation of your androgen receptor that changes the shape so that now these other hormones that are in the system activate the cancer cell and kick them off again and cause resistance. Again, mutations in genes determining whether or not a patient responds to treatment. So we're already there with PARP inhibitors and BRCA, but we are heading into, I suppose, a new era whereby all these treatments that we have are all going to depend on the genomics of your cancer. We're going to have to test for this. And I suppose we're going to have to test quickly. So these patients that we have, they don't have much time to get onto a treatment. And there is a bit of turnaround for genetic tests to come back. So to address this, I've been speaking with SOT, and we've developed a genomic subgroup. And our aims are really to catch up with what's happened over the last few months and then, I suppose, build for the future. So the aims of the subgroup really, first of all, develop a pathway so we can test the germline, so that's the familial risk of our patients. And secondly, to develop a test for somatic changes, starting with BRCA for PARP inhibitors, but hopefully going on into the future to test for other variants. Didn't mention it at the time, but there are some challenges. So I told you about the challenges for germline testing. There are some challenges for somatic testing. And the main problem is that your prostate biopsy tissue that's been sat around for a decade doesn't test very well. They're kept in lots of nasty chemicals, formaldehyde and things like that, which damages the DNA. So the test has quite a high failure rate. So over a third of patients, you'll send off a really good sample and it won't work. And sometimes fresh biopsies do the same. So we have to work a way of sorting that out, because it takes a few weeks to work out if your test's not worked. One solution is to look for the germline. So basically, you could say it's not ideal, but if you've lost a germline BRCA, then there's a good chance that your prostate cancer is a BRCA type of cancer, and therefore we might be able to do that. We might be able to still give you the medicine even if we can't get a test result. Otherwise, you'd have to have another biopsy. So the challenges for our service going forward: capacity. So these tests are quite laborious. They take a long time to come back. At the moment, if we want to test all our patients, we won't be able to do it. There's not the capacity in the lab, so we have to prioritise who we're going to test first. There's a failure rate of the samples. Turnaround tests, some places, we're lucky in Manchester, it's about 3 or 4 weeks, but I believe in other parts of the country it could be 8, 10 weeks. When do we test? So you think, well, maybe we test everyone at diagnosis, but actually some of these genomic alterations occur as your prostate cancer evolves, so you might not be able to test for everything at the start. Pre-test counselling, so we talked about that, telling patients what to expect and how it might affect them. What to do with a positive result? Where do we refer them to? Do we refer them to a geneticist? And also interpretation of the results in the future. So we're all used to seeing scans and listening to Gleason scores and things in the MDT, but actually we'll probably get a printout of altered genes in the future. We'll have to work out what to do with them. So thank you for listening. Sorry about all the cancer biology. But I think this is what we've summarised. So we've summarised bone health. We went into a little bit of detail for that. And then the rest really is about the future, how we're going to move prostate cancer treatment into the genomic age.
Wow, my head's swimming. I don't know what yours is like. I just kind of wrote down some notes here, and I've said this to Noel before, but I just like thinking about what's happening in prostate cancer over the time that I'm aware. So in 1970s, we just had radiotherapy and hormone therapy. And then in the 80s, PSA came along. Then in the 90s, we had radical prostatectomy, started at Stockport and then quickly grew across Manchester. We had truss at the same time. About 20 years ago, brachytherapy came along. Then we got new conformal radiotherapy, didn't we? About 15 years ago and so on. Now we started MR scanning just in the last 3-4 years, all the prostate cancers. Targeted biopsy, new biopsy techniques. Had MDTs for 20 years, but they were new at that time. We've got chemotherapy now, robotic prostatectomy, novel hormones, and now genetics. This is a confusing landscape. And I just think about the MDTs. How on earth do you manage an MDT now and in 2 or 3 years' time when you've got all these treatment options? How are you going to handle it, Andy?
Absolutely. So, this is going to happen now. It should be happening now. We're going to have patients who we're going to get BRCA information on, and we're going to have to decide. And we don't really know. So we don't know whether or not, if you have a BRCA mutation, should you go on a PARP inhibitor first or chemotherapy. But yeah, certainly this is going to dominate the discussion for metastatic patients. And we said about this interpretation, but we're going to get a printout. You can already get it if you at the moment you have to pay to get a genomic profile, but this will be coming for our patients, and we'll need to work out based on that genomic profile how we're going to treat the patient. Now we might have AI to be able to do that, because that's probably a few years off, but certainly now from today we're going to need to be thinking about this in our MDT. Yeah,
I'm looking to the audience to see if we've got any questions. I'm just thinking, I'm as a jobbing urologist, I used to know a reasonable amount. In fact, I've asked Craig a question. Craig, one of our trainees, I'll see him at the back. Stick your hand up, Craig, so we can get you. But I just wonder how on earth we're going to cope. I really do. I don't know enough about prostate cancer now to offer a sensible conversation if we've got a prostate cancer question, and I'm just a jobbing consultant. I think it's becoming more and more specialised, so that the nursing teams and doctor teams have got to really becoming more and more specialised. It's not a urology cancer. I think we're starting to move into the prostate cancer subspecialist nurses and subspecialist doctors. But interested to know your perspective, Craig, as a trainee coming through. Does this excite you, scare you? What do you think?
You'd be excited, I reckon.
All of the above. No, I think what it just shows is the subspecialization of urological oncology, and we're seeing it in surgeons that they're becoming single organ surgeons. It's no longer a case that you're a urological surgeon. You're upper pole, left-sided retroperitoneal partial nephrectomist doing it without a clamp. It just gets a bit crazy. But it does you raise a good question about the MDT. So actually, we have an MDT panel which must consist of at least one of a urologist, one of an oncologist. But now with this subspecialization, do we actually need to take that further? And I know centralization's been a hot topic for the last couple of decades, but I think just locally in our MDT, we often defer to subspecialists within the MDT. And actually, is it okay just to have a urologist if they've not got a special interest in prostate cancer or upper tract urothelial cancer? Maybe we should be redefining who we need on the MDT panel, because largely that does guide the decision or the recommendation that then is transferred to the patient and I suppose proposed to the patient as a treatment option. Andy, what are your thoughts on that?
Oh, so the Christie does. So this is maybe a way off for prostate cancer, but the Christie does have a molecular tumor board. So for the last it must be about the last 7 years, they have a molecular tumor board. So if you've got a cancer that's been tested by them for the genomics, they will meet together and they have a number of scientists and then genomic specialists and then kind of cancer specialists. So there are already these kind of genomic molecular tumor boards. I mean, I think in the future AI will play quite a big role to work out, because obviously you're going to get a printout of loads of different mutations and you need to work out which ones are going to be best. And I think probably the oncologist will, that will probably fall to the oncologist, won't it, to work out which treatment to give. But it's not that far off, and I suppose in some cancers already, maybe not prostate cancer, where they've got a few targets, that is now still that now does probably influence kind of decisions about cancer. And then there is a temporal element as well. So I only briefly touched on it, but your cancer genomics changes as you go through the course of your cancer. So actually, we're going to be bringing more patients back to discuss these things, rather than now. Most of the time, patients get discussed, don't they? And they don't all come back. But actually, are we going to have patients temporarily kind of assessed for their genomics and then having to come back? I mean, I suppose that's a long way off. I don't know how long way. It's probably a while off. But I suppose that the core message today is if I kind of imparted on all of you, I know some of you knew already, but if I can impart on you the difference between germline and somatic testing, I think that will be a success. Because if we all know about that, then we'll know, I suppose, what we're doing with these two different tests to our patients. We're looking for kind of high risk familial kind of elements for the BRCA testing, and then we're looking to test everybody who might be suitable for treatment with a PARP inhibitor. So I suppose that's where we start.
I think you've achieved that, or certainly my brain. We've got one more question here. I'll just kind of introduce it by saying across all of oncology, there's quite a lot of anxiety nationally about the number of new treatments coming on. Breast cancer has just been happening, lung cancer, there's lots of stuff happening. It's just like in prostate cancer here. And there's anxiety about how these are going to be supervised. If oncologists keep seeing them all back in the clinic, it's going to be too much work. So is that something for GPs, or is that something for patients themselves to get more involved in self-monitoring? And that's a conundrum that is a national debate about at the moment, isn't it? Because there's going to be all these new treatments. A lot of them are very personalised. And how on earth are we going to be able to monitor all these patients and all these new drugs? So exciting, but also quite anxiety-provoking. Final question from the floor.
Thanks, Andy. I'm just wondering what your thoughts on triplet therapy and whether suitable patients should be having it up front, or do you keep throwing things, substitutes, things in background just in case?
Oh, so you're talking about triplet therapy in hormone-sensitive disease, having darolutamide and chemotherapy. Well, I suppose that there's been a clinical trial recently that has shown a benefit to that approach. I think we would probably say as an oncology group that the patients have to be, there's an element of selection there for the patients that we think might be able to tolerate kind of that intensification of treatment. I've already kind of shown in that diagram that we're putting a lot of our good things up front, and then at the end, and then when patients become kind of hormone refractory, and this doesn't mean that chemotherapy is still very good, but you know, we are loading our treatment at the start. It remains to be seen, I suppose, whether or not that improves the overall survival for the patients. Now, the jury's out at the moment. We're not quite sure. I suppose the good news is, if we've got these other agents coming through, then maybe having intensification at the start means that we don't burn through all of our options at the start. So I think it's generally accepted, and there are a number of treatment strategies, not just with the one that's been approved, but using other agents, PARP inhibitors, for example. So that's the next thing, PARP inhibitors given early on. So I think there is general thought that using everything you've got and try and get a low burden of disease to try and reduce the amount of resistance, that's a general oncological theory I think that we follow. So I think there is a lot in that, but I suppose it remains to be seen whether or not that translates to a survival benefit for the patient.
Excellent. We've not even spoke about checkpoint inhibitors or all those other
Oh,
kind
yeah,
of things.
absolutely,
Right.
yeah.
So thanks very much, everyone. Join me in thanking Andy. So we're going to take a break now. There is a final session, which I do encourage you all to hang around for. It's a three quick 10-minute presentations by trainees on really topical subjects. So if we can just have 10-minute maximum break, come back in with your coffee. So certainly promptly at past, we'll resume on the final section. Thanks very much.